And then this is when you go forward, backward. So
Go ahead.
you got it.
Good afternoon, everyone. My name is Tim Morris. I'm the chair of the Mission Committee at the American Lung Association, pulmonary physician at the University of Colorado. The Lung Association has generated a number of seminars, such as the one we have today, and they're on various different topics, and you can certainly check that out in the Lung Association website. Today's topic is going to concern lung cancer screening, which is potentially one of the most life-saving interventions that you can make in lung medicine. We have assembled a team of experts to discuss this with us. And I'd like to, first of all, I want to thank the American Lung Association for producing this series. In particular, I'd like to thank Sharp San Diego Healthcare for their support, and especially the Sharp Grossmont Healthcare District for giving us this beautiful venue for our talks today. Today, we're going to have a great program for you. We have Dr. Kaveh Bagheri and Dr. Klijian. Dr. Bagheri is an expert pulmonologist in the diagnosis of and management of patients who have lung cancer and other lung diseases. And Dr. Klijian is the thoracic surgeon who takes care of the curative and treatment surgeries for those patients. In addition, we have a panel that is going to hopefully give us a lively discussion afterwards. We have Dr. Mike Welch, who is a longstanding volunteer for the American Lung Association and is going to talk with us a little bit about some of the Lung Association's efforts in lung cancer screening, including a very special event that we have going on May 5th. But we also have Dr. Mark Fuster, who is an expert in the biology of lung cancer and also in the diagnosis and management of lung cancer. He is a University of California, San Diego pulmonologist. And also Dr. George Cheng, who is a interventional pulmonologist who is in charge of some of the diagnostic procedures that we have to evaluate lung cancer. So we're going to start off with a presentation by Dr. Bagheri and Dr. Klijian regarding lung cancer screening, and then we'll join them in a panel discussion. Dr. Bagheri.
Thank you. Thank you, Dr. Morris, and good evening. Thank you all for being here. Over the next 10-15 minutes, Dr. Klijian and I are going to go over the very basics of the lung cancer screening. Before we talk about lung cancer screening, I just want to mention a few words about what is screening. When you pick a test to see if you can make a diagnosis of a disease before the symptoms, that is a screening. And so the goal of screening is early detection. So some of the examples of the screening that many people are familiar with is, for example, mammogram. We know mammogram is used as a screening for breast cancer. Colonoscopy is another screening test for early detection of colon cancer. So these are the tests which is done as a screening, and it can detect the disease before symptoms present. Pap smear for cervical cancer. But some of the very basic tests, such as testing for blood sugar for early diagnosis of diabetes, checking a blood pressure for early diagnosis of hypertension, doing a blood test on cholesterol to diagnose someone who may have hyperlipidemia. Remember, none of these people have any symptoms. So if we don't do the screening, the disease will not be detected until many years later. In case of lung cancer, it's the leading cause of cancer-related death in both men and women, even though it is not the most common cancer, but it is the leading cause of death. So it is a deadly disease, and the reason is traditionally it was diagnosed in later stages. So what if we could make an earlier diagnosis? And before we talk about diagnosis, I like to emphasize the prevention, because prevention can really make a big difference in preventing the disease from happening. In the case of lung cancer, we know that smoking is the #1 risk factor for development of lung cancer. One point which is very important is when people quit smoking, it still takes many years before the risk of lung cancer returns to a non-smoker individual. So again, I would like to emphasize on prevention, which is do not start smoking. And then if the individual is a smoker, we really need to focus on smoking cessation. And I really want to thank American Lung Association because they have been a big advocate in anti-smoking movement in order to prevent especially younger individuals from starting to smoke. And of course, their campaign on smoking cessation. So we know that lung cancer screening can detect lung cancer in a much earlier stages. And we know if you can diagnose the lung cancer in the early stage, you can even reach cure. So lung cancer screening will save lives.
Question comes up, who should be screened? The question comes up, who should be screened? Obviously, it's going to be the patients that are at highest risk. Currently, the screening criteria must include all three of the following: 50 to 80 years of age, greater than 20-pack year smoking history, and currently smoking or having quit within the last 15 years. A lot of people are concerned about the radiation that's associated with the screening. And I wanted to mention that the dose of a screening CT scan is not the same as that of a conventional CT scan. It's a significantly lower dose. Conventional chest CT has about 7 microsieverts of radiation, whereas the low dose screening CT scan for chest has only 1.5 microsieverts. So it's 80% lower than the traditional CAT scan. Slightly higher than a traditional chest x-ray, but significantly better visualization of tumors that may be manifesting early on. Why is it important to screen? Well, the scan, which was first kind of done under the LCAP trial, which stands for Early Lung Cancer Action Project. It was a study done by a radiologist from Cornell named Claudia Hensky. And she did the study where she took a group of patients and did traditional chest x-rays to screen compared to low-dose radiation lung cancer screens. And the screens were significantly better with the CT scan as opposed to the chest x-ray in picking up these very early smaller lesions. And that translates to survival benefit. The earlier that we can get to these lesions and treat them, whether it's through a surgical approach or through other approaches, stage is paramount in terms of causing survival benefit. And here you can see a schematic of what might be manifest. In the first corner, we could see that it's very small area on plain chest x-ray is clearly not visible. Areas that start to develop may or may not even be picked up. It's only later on in the course of the disease when the process is, greater than a dime or a nickel or perhaps even a quarter in size that they start manifesting on plain chest x-ray. And at that point, you're talking about a much later stage of disease. Some people may not be willing to have a scan because of concerns about having something show up. Well, I want to address that head on and say that it's important to get the scan because if you pick up these things early in the course of the disease, we can have a significant impact on survival. We can get you through the treatment course and get you to a course of survival much better than picking up in the later stage of the disease process. So the scan gives us a bunch of different information. We not only see the pulmonary nodule, but we can get characteristics of it. We can see jagged edges, which may suggest malignancy. We can do three-dimensional reconstruction of these images to see if they're smooth and round, which would be more consistent with a benign process, or jagged and spiculated. which tend to appear more aggressive, which would suggest a malignancy. They also give us information on the location of it. Is it something that we can easily diagnose with a needle biopsy from the outside, or through a surgical biopsy, or a different form of biopsy, which we'll go into shortly. And it also gives us information about other things. Is it attached to the chest wall? Is it attached to the diaphragm? Are there any lymph nodes that are visible? All of this kind of goes hand in hand. The beauty of the lung cancer screen is that we're picking up lesions at an earlier stage, so much so that even the pathologic classification on some of these lesions have changed. Traditionally, when we take the patient to surgery and take out a lung cancer, stage 1 would be considered the earliest form of cancer, and still is, but it got subcategorized because we're picking up lesions that are smaller than my pinky nail. And when you're talking about sub-centimeter lesions, we're really focusing on a different survival rate than with the larger lesions. They tend not to have metastatic disease associated with them. Lymph nodes tend not to be involved, and that goes very well with survival benefit. It changed so much that a pathologist from Japan named Nikuchi came up with a classification scheme where he subcategorized these very early lung cancers from A to F. And the first two, A and B, are really super select group of very small lung cancers that have 100% survival with treatment compared to some of the other more advanced stages. The PET scan is another alternative as well, another test that we have at our option, and that really shows us whether or not there's metabolic activity, which when the area of the lesion lights up, it is suggestive, depending on the degree of uptake, with potential malignancy. And it also gives us information about the lymph nodes. So we have an understanding of what the stage is before we go to make a determination on treatment. The other approaches we have to try to establish the diagnosis include a transthoracic needle, which is often done under radiologic guidance, whether it's ultrasound or CT scan. A needle is placed by the radiologist into the lesion and biopsies are obtained so we can actually have an answer without necessitating more invasive procedures. The other approach I'm going to let Dr. Bagheri mention is robotic-assisted bronchoscopy.
So as Dr. Klijian mentioned, we do the screening and we will find some nodules. Now the question is, which one of these nodules require intervention? So PET scan is one of the non-invasive radiographic studies that we can do. Then we may require a tissue diagnosis. That is when we need to do a biopsy. The technology has significantly improved. One of the traditional ways was by our interventional radiology colleagues doing the biopsy from outside the chest, as we saw on this slide. So you can see that the needle enters the shadow, which is that nodule, and a biopsy is obtained. But now, many of our centers in San Diego and all over the country are equipped with what is called a robotic-assisted bronchoscopy. And we actually have a world expert on our panel, which will be talking more about it. But this will give us the ability to obtain tissue biopsy and diagnoses from inside of the lung tissue. There are some blood tests. The technology is improving, and this is when you find a nodule in a patient who is at a higher risk. You can actually do a blood test, and by certain type of proteins and biomarkers, it kind of gives screen and increase or decrease the risk of malignancy in these nodules. So I guess at this time we'll stop, and Dr. Morris will moderate the question and answer part.
Well, thank you very much for that summary. That was great. I do want to focus on one thing that you had said, I believe Dr. Klijian said,
about that one of the advantages of lung cancer screening is actually when you pair it with smoking cessation. And it turns out that that is one of the life-saving procedures that a healthcare system can do, is to pair the two together. And Dr. Welch, I wonder if you could tell us just a little bit about the Lung Association's efforts towards smoking cessation, and then maybe you could tell us about this event that's being planned in May.
To. So I've been a long-time volunteer for the American Lung Association and have always been excited about the programs they have for helping my patients and your patients on the panel. An important one is smoke cessation, and they've had for a long time and have modernized over and over again their program that they offer the public for smoke cessation, and which is a key part of what we're talking about here today. There's also an important initiative going on related to lung cancer that the American Lung Association here in San Diego has started to extend screening services into the community, particularly the underserved community, to be able to get people into the system where they get early screening, smoke cessation, and so forth. So there's a hard focus to really do a better job than what we're doing right now in San Diego. And it's called the San Diego Lung Cancer Initiative. So that's exciting. And that's just sort of getting off the ground. But the fun part of what Dr. Morse is referring to is a fundraiser, a fun fundraiser coming up on Cinco de Mayo at Liberty Station, and where we're going to gather together, as we have for many years with the ALA, and celebrate, all the different services the American Lung Association has to offer. It's connected with fundraising. You have teams, you raise money. It's going to be a fun time with exhibits, and we're going to have a lung tent where you're going to be able to see live animal lungs. You're going to be doing bronchoscopy in a way, in live action. So I really encourage people. That's May 5th, Liberty Station, and come out and have a good fun time while raising good funds for a very important cause.
That's great, Dr. Welch, and we'll see you there. And my team's going to be your team, by the way. So let me start off the question to the lung cancer experts here, and I'm going to ask a real plain question, which is, are there forms of lung cancer that can be detected on screening that a person doesn't know they have, and they get detected and they get cured and they go back to the life that they had before this all happened, that they come in, they see one of you or several of you, and they return and it's like they're okay? Is that possible?
Happy to take it. Yeah, thank you, Tim, for that great question. Thank you, Dr. Morris. Again, and thank the ALA and all of you for allowing me to be here as part of this great panel. I would say an absolute big yes to this. It's become a more firm yes over the years that we've been able to detect very early lung cancers. And is there a kind? Well, we have lung cancer in many flavors. There's typically separated into two big kinds: non-small cell, which is most of lung cancer, and something called small cell lung cancer that tends to spread by metastasis and throughout the body a bit more aggressively. But even the non-small cell can spread fairly early. And any of these varieties can be detected, I think, to the point of Dr. Klijian was making, quite early when you were going over the history of this. And we found that we can impact the mortality of the disease and move it from in that national lung screening trial that was done with many thousands of patients, to pick up the disease at an earlier stage when it's more curable. And the disease I speak about is these subtypes of non-small cell lung cancer. There's a few different types, but suffice to say, they all behave kind of in terms of spread in the body similarly, quite aggressive, and best picked up early. And smoking, for the most part, puts most patients with that disease at risk of getting this. And there's the other type, small cell, that now actually technology's moved so far that picking up even that one early can be a curative approach in the whole group of them. So, yeah.
Dr. Klijian, do you send people home back to their normal lives after lung cancer diagnosis?
Absolutely, it happens quite frequently. Surgery has changed over the past 5 years even. We're getting to do things, whether you do it robotically or whether you do it through the thoracoscope, or through this new technique that I've been doing for about 12 years now called AVATS, which is done under a local anesthetic with sedation through a single incision, oftentimes with a single incision using the camera. You can do the lobectomy or even segmentectomy, where you're removing a part of that lung. So you don't have to even take the entire lobe of the lung. You're just taking a segment of that lung out. And we've had probably about 80 patients go home the same day as resection. And the length of stay now for a lobectomy hovers around 1.2 to 1.3 days.
Dr. Cheng, I'd heard something about people getting diagnosed and treated the exact same day. Is that possible?
Yeah, absolutely. I think. Yeah, absolutely. Thank you, Dr. Morris, for the question. And also thanks to the American Lung Association for this opportunity to bring me here. It's a pleasure to share the stage with Dr. Bagheri and Dr. Klijian. I read Dr. Klijian's paper on his awake resection papers. It's quite impressive. And when I still recall the first time when I read that paper, I was wondering, how is this not being done more so? Because it seems like the thoracic surgery, when you can reduce the anesthesia time and you can actually shorten the time for the patient to of going from surgery to go home, all these added benefit makes it such an impactful study. So congratulations and thank you for that.
Yeah, no, thank you very much. Yeah, and to answer your question, it is starting to pick up. There's certain number of surgical tricks that you have to have because the visualization is quite different than the traditional approach. And the typical lung operation and what's done under a general anesthetic, we even do a selective ventilation of the lobe of the lung or the lung that we're working on so that the lung is kind of deflated and gives us a lot of area to work in. When doing it through this awake technique, the patient's actually breathing during it, spontaneously breathing. And so it's kind of parallels to off-pump coronary bypasses. You know how bypass surgery in the olden days required the heart being at a complete standstill and going on heart-lung bypass, and that the bypasses now can also be done under a beating heart technique. But there are surgical techniques and tricks that you have to do to get visualization. There's a learning curve associated.
I can imagine. And in fact, just getting back to Dr. Moore's question earlier, what we are able to achieve nowadays, as Dr. Bagheri was mentioning, that we are now moving away from transthoracic type of biopsies and moving more towards a robotic assisted bronchoscopy for diagnosis and evaluation of these lung nodules. And the reason for that is really quite evident. When you take a needle going through your chest wall, purposely puncturing the lung in order to get a piece of tissue for diagnosis, the actual movement of that needle through the covering of the lung puts you at risk for developing collapsed lung, just like you would pop a balloon with a needle. So with transthoracic needle aspiration, the risk of pneumothoraces is somewhere around about a quarter, around 25%, 1 in 4. So, but when you look at the robotic assisted bronchoscopy, the risk of developing a pneumothorax or a collapsed lung is 1% to 2%. So you're looking at tenfold less risk of developing collapsed lung. And secondly, we also are able to stage our patients at the same procedure. So what that means is after the robotic bronchoscopy is performed, after we do the biopsy and suppose the nodule turn out to be cancerous, we can actually assess the lymph nodes at the same time. So by using these cameras with an ultrasound probe that is at the very end of these cameras, that we can actually look inside the chest with ultrasound to identify where the lymph node stations are. And we're able to sneak in a small needle to sample those lymph nodes and figure out if those lymph nodes have tumors involved. And if the lymph nodes do not have any tumor involved, then at the same procedure, in the same anesthetic event, we can ask our thoracic surgeon colleagues to come in and do the resection at the same time. So the patient will come to our OR with a undifferentiated lung nodule, go home already treated the same day. So we're at that juncture to provide what we call a single anesthetic event, or at our program we call a STREAM LC, or a single thoracic robotic assisted event with anesthesia for management of lung cancer.
Dr. Bagheri and Dr. Cheng, could you help a little bit with our understanding of what a robotic bronchoscopy means? I mean, when I heard it, I thought it'd be maybe you guys are going to be sitting having a cup of coffee and you'd send a robot in and he'd take care of everything. But it has more to do with being able to control fine movements that used to be just your touch and your vision and your sense of touch, right? So things are advanced, but can you explain how is that advanced?
Yeah, it's really truly remarkable. In the past 5 years, just in a short 5 years, what has happened in the field of bronchoscopy and pulmonology, or diagnosis of lung nodules. There's a paradigm shift that I mentioned earlier in terms of using robotic bronchoscopy, robotic assisted bronchoscopy to perform diagnosis and evaluation. The reason for us to use a robot is because we actually are able to achieve a highest degree of accuracy than we have ever been able to do before with just a simple robotic, just a simple bronchoscope or a camera with a tube in the end. So how do we do that? Well, we actually take a CT scan for our patients where this lung nodule is detected, and we actually use a computer to 3D reconstruct the airways for our patients. So you actually see the entire airway from your largest airway, the windpipe, going to the lower airways, all the way branching out into these periphery small airways, less than 3 millimeters in some cases. And we then use this map that we created, and we tell the computer, well, here is my nodule, find me a pathway. And the computer finds us a pathway, and then it will feed that plan, this planned GPS route that we have generated, to the nodule as our destination, and feed that plan to the robot.
Like Google Maps?
Like Google Maps, effectively. Sounds like science fiction, but that happens every single day. Every single day. And effectively, what we are able to do now is to have a very stable robotic catheter that we drive either by using a joystick, almost like an Xbox joystick, as Dr. Bagheri have shown, or a rollerball and an advancement wheel that allows us to move the robotic catheter. These catheters are in the size of about 3.5 millimeters in diameter, all the way out into the periphery of the lung. And then once we get to that periphery of the lung, it stays in that shape. It completely anchors itself and allows us to pass different tools through this catheter, through this robotic catheter, and do the biopsy, and potentially in the near future, offer therapeutic options as well.
Dr. Bagheri, I wonder if you could address, there may be people who are watching this demonstration here saying like, I've heard about, warning signs of cancer, coughing blood up and chest pain and chronic coughing. I'll just wait until that sort of stuff happens. I'm fine now. So why should somebody who's watching this, sign up for lung cancer screening? What's the advantage to them of doing it now?
So that's a great question. We know that there are many different reasons why people do not want to undergo screening. One of them is especially for people who continue to smoke. When we talk to them about the screening process, we also talk to them about smoking cessation. And that unfortunately can turn off some people from going through the screening. So I think it is really important to be able to have the dialogue in the way that they do not feel threatened. Even if they don't have a plan of smoking cessation, we should still offer them that screening process. Then the next thing is, I think there is a very high level of anxiety that actually I was going to ask one of my colleagues who is actually much more experienced, is from the time we do the screening and a nodule is detected, we know that many of these nodules, as a matter of fact, majority of them are benign. but the stress level, the anxiety level is very high. So what is the best way to approach that?
Yeah, so I'll answer that. Seeing a lot of screening, for example, I run the screening program in our VA hospital, and the VA is making a large effort to understand how to not only screen within the right confines and have all the downstream services that you've been hearing about in a very high-risk population, but also counsel patients and have shared decision-making the right way. So it's a question we can all ask each other. And here, you're appropriately asking me, what do I tell a patient? You have a nodule, now what? And I think one of the things is perhaps in this day and age, after hearing some of the technology, I have my colleagues that run an entire team in knowing I can have confidence that I can do this more safely now if I have to approach a nodule where it's high risk and I consider it lung cancer, that it can be done that way. So there's half the game is telling them that fear not, things are actually moved in such a tremendous advance that we can do it much more safely and much with lower risks of spreading cancer or causing other complications. The other side is that, a little to your point about if not all nodules are created the same. And so sometimes, and I would say the vast majority of what we call incidental findings, nodules on a CAT scan, on a screening CAT scan, are actually something that never becomes cancer. And in fact, many of us, as many as over half to 2/3 of veterans, and maybe 1/3 to a half of non-veterans who haven't seen the same exposures, are walking around with small nodules, typically nodules that are much less than half an inch, than a centimeter. And those types of nodules, typically in the millimeters range, we see them and then we don't ignore them because they could be a cancer. But that's part of the importance of close follow-up and having this shared decision-making, that you've made a move to know you're a high-risk person. And now we have technology that if it looks like something scarier, we can do something and have caught it early and save a life much earlier. But if we catch one of these incidentals, which happens much more often, you're now in good hands for repeated screening. It's a low dose screen, as you brought up. So the amount of radiation and following a small nodule is very low, and we don't have to intervene on the vast majority of these. So in a way, you can counsel many, many patients. The vast majority, we picked up something. Let's say it's about 5 millimeters in size or 6 millimeters, and the patient is at risk and is a smoker. You shouldn't lose sleep that this is cancer. It's most likely not, because we get the luxury of a repeat scan to follow it down the line. But at the same time, I'm so glad you came and had this done, because now we can follow it. And if anything grows or looks more concerning, or if we picked up something bigger like an 8 millimeter or a 1 centimeter nodule, we actually have technology that even when it's quite far out, I have the hands of my colleagues in interventional pulmonary that if we need a biopsy, we can go to them and get it done relatively safely through the technology that was being brought up earlier.
So just to be clear, Dr. Fuster, there are scan results where the answer may be, I see it, and we're gonna watch it and make sure it doesn't hurt you.
Absolutely. And there's whole protocols that are come off of an entire system called LungRads, and it gets updated. Our radiologists have recommendations built right into those that go to the physician ordering it, the patient, and there's actually timelines for actually how long you wait between watching and in close hands, knowing that you always have your colleagues, these expert friends of ours, that can do amazing things if something ever gets more concerning. So it's kind of well.
If I may just add to that also, there are apps on our cell phones that we can download, and you can put the information about the patient and the nodule, and it will give us a risk stratification. And if it is a low risk nodule, then observation is definitely the approach.
And I think that just to kind of piggyback on that, I think there's a lot of stigma that's associated with lung cancer screening, especially when you look at the requirements. Requirements is smokers. A lot of times people think, I did this to myself. And our point is, please don't think it that way, because we want to offer you the best care that we can. And in order to do that, and we know lung cancer screening will save your life. It reduces mortality by 20%. If we detect it earlier, we can make a difference. And so So don't think that just because I smoked, once I get a nodule detected on a CT scan, I'm finished. I'm done. That's just cancer. That's not the case. That's absolutely not the case. Even in our highest risk population, for those heavy smokers, when the nodule is detected, more often than not, the nodule is benign. The chance is in your court. So please do screen.
Dr. Klijian, you were trying to say something there.
Yeah, and I was just going to circle back to your comment earlier about the patient who doesn't have symptoms, why it's important to get screened. And I want to draw a parallel to the heart again. You know, patients have silent heart attacks all the time. They don't necessarily have to have the crushing chest pain to have a heart attack. Very similar in the lung cancer arena, those signs that we talk about, the cough, the coughing up blood, the weight loss, those tend to be late findings in lung cancer, which are typically associated with more advanced disease. We want to find the patient who has the stage way earlier than that, which will oftentimes be without any of these findings, any of these signs. So it's important, even if you are totally asymptomatic. In fact, that's what the whole point of the screen is. It's to treat or screen asymptomatic patients.
Let me say something. I think a part of this whole problem that the Lung Association tries to educate about is that even if you stop smoking, you're fine. I think there's a perception in public that that's the case, and I think before to even get into the hands of all these phenomenal physicians who can deal with it when it's detected, they have to take that first step to get the screen and so forth. But so often the public's not educated about the fact that you're still at risk. What is it 5 to 10 years out? Is that right? That's the number you're using. And so I think there's a certain amount of misperception that the Lung Association has to work on to make sure that that we're getting the appropriate patients in and not just the ones who are active smokers. So. And I think all Lung Association is doing a good job of doing that.
So there is a number to that cessation sign, and it's typically a little, even more than 10 years for it to really go into like almost hit I'm at the same risk, I think what Dr. Bagheri was bringing in the talk earlier, as anyone in the population. So we're always high five. The longer you can be off, the longer you're making progress. Your risk is going down as we watch with time, and it's a safe way to watch right now. Plus, we know that there is some time that the kind of teams adjudicated for what's safe in terms of where you're at risk. And if you stopped smoking 5 years ago, you're still at high enough risk if you smoked a certain amount to watch about 10 more years. So even those rules we're watching a lot of people. They're sort of changing, but it's just basically how long you smoked and the dose that's the biggest deal. Yeah. And that washout over time that really matters a lot. Mm-hmm. But I will say back to Dr. Cheng's point about having a very safe technology, but a technology that we're watching and have the tools to deal with. It's amazing that when we looked at this as a trial in thousands of people, what something that all of epidemiologists, people that study outcomes, call a number needed to screen to save a life. And the NNS, or the number needed to screen in lung cancer screening, with this 20% reduction in mortality, is one of the best of all cancers. It outdid mammography, it outdid a number. It's just you got to go kind of deep to get an answer sometimes, take a more of a risk. And now we've moved that deep point from a transthoracic biopsy to something you can actually do a lot like Dr. Cheng was just teaching us. You can get a lot further and get an answer in a much safer way. So what a combo to have a very strong number needed to screen and a technology now that makes it much safer.
Before we leave Dr. Welch, you had brought up smoking cessation. I do want to go back to what you had said in a moment, Dr. Fuster, but I think it's important to realize that smoking cessation is different now than it used to be. It used to be that the model for smoking cessation was we would wait for a patient to come to us and say, okay, are you ready? And when until you're ready, knock yourself out. And as soon as you're ready, you let us know and we'll make a plan with you. But there has been some developments where there's some medications and some other types of things that can be done for people, even if they're not ready to stop smoking, to make them ready to stop smoking and to actually, to prepare the way for doing that. So by all means, if this conference has made you think twice about smoking and you're considering quitting smoking, you don't have to, kind of hold your breath and say, I'm going to charge ahead in order for us to be able to help you. Your doctor can provide things that can help with that. Dr. Cheng, you were going to say.
Yeah, absolutely. I think just kind of piggyback off on Dr. Welch's comment in terms of education. I think national societies are recognizing that as well in terms of the risk doesn't really decrease significantly after the years of smoking. I think there is a movement to start modifying the lung cancer screening criteria that will actually eliminate the number of pack years, not number of pack years, but the number of years since quitting an active smoker. So that particular criteria, the third criteria, 15 years quit within the past 15 years, that will very likely in the near future go away completely.
Interesting.
Which is getting back to your point.
Yeah.
Don't think that if you quit smoking and then you're back on normal track.
Yeah, it's going to
not.
make it even harder then to make sure you get the message out that
wonder
you're
if
still at risk, even though you're pretty far out.
What if I could ask the panel now about maybe kind of the other side of this? We talked about prevention by stopping smoking and early detection, but what if somebody were to get one of these lung cancer screening scans and it showed advanced cancer? And it wasn't just a small, something the size of a, kernel of corn or something like that, that could be easily taken out. Are we kind of now doomed to, chemotherapy and, kind of progression that way? Or maybe we could talk about some of the new therapies that are out there that really developed in the last few years that can take advantage of the body's own mechanisms to eliminate lung cancer, or at least treat it.
Yeah, happy to chime in on that one if that's okay. I do think that's a great point. And, I mentioned earlier this stage shift that we pick it up earlier and we can come to our interventional, surgical, sometimes radiation oncology colleagues to cure the cancer. But it's tougher, but it's not, it's far from game over when you pick it up early. And we've moved the technology and advances in oncology in picking up what we call advanced stage lung cancer. So that's where it's moved to the middle of the chest. Some of the lymph nodes are involved. That's what Dr. Cheng was talking about, staging, or it's spread to other parts of the body, sometimes the liver, the brain, these other glands, the adrenal glands, or to bone. It does spread to some places. And if that's picked up in your workup for lung cancer, it's come a long way. So as Dr. Morris mentioned, we've had chemotherapy for years, but so many advances have happened in the last 5 to 10 to 20 years. It's amazing. In the last 5, there was Nobel Prize winning work on something called immunotherapy. And you correctly alluded to the body's ability to deal with the cancer. So we can give special antibody therapies through the oncologists where we empower your immune system that fights cancer at least as good, if not better, when it's spread through the body as chemotherapy. And there are targeted therapies. So we have specific markers in the cancer that can be detected where we can fight it with specific drugs that specifically target that little change in the tumor that's making it grow aggressively. We can pair those with other therapies, with some radiation and other things to make it a much more effective treatment, and the mortality has markedly improved with these types of therapies in advanced stage lung cancer, to the point where we see many more cures even with advanced stage lung cancer. And so it's moved a long way. It's safer. We pair a number of therapies, and a liquid biopsy and other forms of biopsy were mentioned earlier. And these there's molecular testing that we can do on the sample that tests for all these special markers or the immune response that we can use tools for. We talk about those in a group, in a tumor board, and refer the patient to the right groups of treatment that are, again, much more effective and where outcomes have gotten much better over the years.
And Dr. Morris, it's also important to highlight that lung cancer, as opposed to other diseases, is not a one physician treatment. It's the team approach that often works best with lung cancer. That's why we have tumor boards. That's why we continuously talk to our oncologists, our pulmonologists, our radiation oncologists, the surgeons, as well as the patient's primary physician, and oftentimes other physicians make sure that the cardiac status is fine to undergo treatments and whatnot. So it really is a team approach to treating cancer.
I also like to add that I think a lot of our patients are in the age group that they recall many of their friends or family were treated for lung cancer and their side effect of the treatment was worse than the disease. So many times when we speak to the patients about screening, they said, they may mention, I don't even want to know because if I have cancer, I'm not going to have a treatment. Or in the case that you brought up, Dr. Morris, is let's say we do a screening, but we find an advanced disease. Many of the patients, the first reaction is, I do not want any treatment because I don't want to get sick. I don't want to lose my hair. And I think that is so important, as you mentioned, that we talk about all the new modes of therapy that we have. Management and treatment of lung cancer has changed significantly. And I think that is where it is so important to take time with the patient because we just gave them bad news. It's already emotional. They may have memories of bad memories of family and friends. Uh, and we can give them hope because the immunotherapy, as you mentioned, it really does miracle.
Talk about that immunotherapy, or ask you guys about the immunotherapy for a moment. And so the way I envision this is almost like our own cells are walking around with ID tags on it. It keeps our immune system from killing our cells. And cancer has somehow figured out how to make, fake ID tags, and they kind of get away with it. And this immune therapy seems like it's almost like a way of taking the fake IDs away from the cancer cells. So the immune system will kind of to take care, kill those cells as if they're invaders. Am I on the right track there?
Yeah, I think that's cancer has definitely, to your point, Dr. Morris, figured out some ways to turn on the injectors to any what we call T cells, immune cells, to shut them off as they approach the cancer. It's kind of learned your body's what we call homeostatic mechanisms. You have mechanisms so that when you get an infection or something foreign, your immune system doesn't go rampant and kill you in this wild flame. So it's used the same mechanisms. But the nice thing about these therapies is they actually are helping to ramp up the system. They don't really turn it into flames. There are some side effects to that world. And so we always are watching for what we call autoimmune side effects. They happen sometimes, but they do not happen in the majority of cases. In fact, it's the minority of cases. And the overall effects of adverse effects, when you compare those to chemotherapy as a first-line therapy in metastatic lung cancer, it's an overall better program with less overall morbidity and mortality, having some of that rather than, and they're quite rare, but you're monitored for them, than the chemotherapy side effects.
And I believe the chemotherapy side effects are the ones, Dr. Bagheri, that you were alluding to about, the hair loss and the, weight loss and the extra infections and that sort of thing. It seems like a different beast.
Yes, the traditional treatment going back to 20 years ago. So that has completely changed. Even if we look at the radiation therapy, it has changed so much because before you would radiate the whole chest and you had so many side effects, but now it is really laser focused to the tumor. So technology for diagnoses, as Dr. Cheng mentioned with the robotic, and then the modes of therapy has really changed the management of lung cancer.
I would just interject that we can actually, it's a very good point to mention to Dr. Cheng. I can often look to Dr. Cheng's team in getting a biopsy and learning from the biopsy, even though it's quite small, a wealth of information that helps guide our therapies, even if it's kind of an intermediate or we don't quite know stage until it's done staging. So we can start some of that stuff early in coordination with our surgeons. Sometimes it can be done before surgery to even get a better outcome. I don't know if Dr. Cheng wants to mention some of that, but
Yeah,
it's amazing what you can do.
So with the robotic bronchoscopies and the way that we approach our biopsies, not only are, like the panelists here already mentioned, that we can do it safer, we can get to ever so smaller nodules, ever so small in the periphery. Therefore, shorten the time of waiting. As mentioned earlier, got a small nodule. Can we get to it? Well, I think we can. And how small can you get to it, Dr. Cheng, or Dr. Cheng's partners, or Dr. Bagheri and his partners here? I think previously we would say 2 centimeter or above, no problem. 2 centimeter less is a little bit of a problem. So that's about a little bit smaller than an inch. Now we say less than 1 centimeter. Okay, no problem. Less than 5 millimeters. All right, maybe we're going to be spending a little time. So our threshold of being accurately giving a diagnosis have dropped significantly because of the robotic assisted bronchoscopy. What does that offer to our patients? Well, each one of those biopsies, we can send it for genetic testing, for mutational analysis, and that the biopsy result will drive some of these systemic treatment that if you require systemic treatment. But as we are getting smaller and smaller in terms of earlier and earlier in terms of diagnosis, i.e. the smaller and smaller the lung nodule that we're able to assess, we make the job for Dr. Klijian much easier. If there's these small nodules in the periphery, instead of removing a whole bunch of lung tissue, like entire lobe, maybe we can get away from just removing a small segment. So I would love to hear Dr. Klijian's thoughts about the difference between a lobectomy versus a segmentectomy or just a small wedge resection on early lung cancer.
Could you explain those terms just so for the
Absolutely. A lobectomy refers to removing the entire lobe of the lung. On the right side, we have 3 lobes. On the left side, we have an upper lobe and a lower lobe. And a portion of the upper lobe is called the lingula, but really 2 lobes on the left. A lobectomy is requiring removal of that entire lobe, whether it's the upper lobe or the lower lobe, or in the case of the right middle lobe, taking the entire lobe out. There are benefits to that, especially with larger tumors at more advanced stages in terms of 5-year recurrence rates. The recurrence rates are much lower if you take out the whole lobe and do a full nodal dissection. Problem with that is that with the smaller lesions, you're removing a lot of lung tissue, a lot of times in patients who have somewhat be younger and may develop a secondary tumor down the line. And so in the very early lung cancers, the ones that are less than 2 meters or even 1.5 centimeter in size, the segmentectomy, where you actually go within the lobe, but remove the specific segment within that lobe and preserve the remainder of that lobe.
a segment is a section of a lobe?
Taking a section of a lobe. That's not to be mixed up with what's called a wedge resection, which is just oftentimes where it's done for diagnostic purposes, where you're just randomly removing a wedge of tissue, a triangular section of tissue. This is actually removing the segment within the lobe. And on the early lung cancers, the ones that are less than 1.5 centimeters, that recurrence data is similar to lobectomy without having to take the entire lobe. So you preserve more lung function. And if a patient were to develop a secondary site somewhere down the line, they can potentially be afforded a secondary operation because you haven't taken out an entire lobe of lung. And we can do those through the use of the camera, through small incisions. And surgery has changed dramatically over the past 10 years. I can actually let Dr. Bagheri let you perhaps tell about how patients used to come out after lung surgery versus what we can accomplish now.
So as Dr. Klijian brought up a very important point, most of these patients with diagnosis of lung cancer have long history of smoking, and they have underlying lung disease. So things such as emphysema or chronic obstructive pulmonary disease. So their lung function is already very low. In the past, there were very specific criteria for who can tolerate the surgery. But now the techniques have improved. And also, as Dr. Klijian mentioned, we are doing lung preserving surgeries. We're not taking the whole lobe out if it doesn't need to come out. Many years ago, the technique was just not available. Our surgeons were not trained anatomically and the technology, but now having the art of doing segmentectomy, which is just taking part of the lobe out in people who have underlying lung disease, really doesn't affect their quality of life on long-term basis.
Great. Dr. Cheng said something that was intriguing, that he said that when he takes some of the biopsies out, especially even some of the larger cancers, that he'll do a genetic analysis and look for mutations. And presumably that's to see if there's some vulnerabilities that the cancer might have, just some special tricks. Dr. Fuster, Dr. Bagheri, could you talk about some of those special tricks that we can do if we see these vulnerabilities on the genetic scan?
Sure. Yeah. On the happy to take one. Yeah. If you take the biopsy, can as sort of the point when I was prompting Dr. Cheng earlier, quite small piece, so it doesn't take a lot, and you can go quite far out. He might be, for example, or he and his team might be, or your team might be going after something that's not just a primary lung cancer, but even in the case where we don't know what's going on, a metastasis from even to stage a lung cancer and get the tissue, and that's where it can even matter more. To get just the markers that help us know what is this cancer producing that drives its growth. And so if we have specific markers, they're these targeted sort of what we call molecular targets. When we find one of those, that's the primary therapy when cancer has been kind of more advanced. And it's much safer than chemotherapy. At the same time, we'll look for what we call the propensity to immunotherapy. So there's a marker for that, something called PDL1 that the tumor makes. And that's a way that we can learn that it's going to be immunoresponsive. And now let me back up a little. We can actually get these markers during the time of staging when someone isn't even metastatic, but the disease has spread kind of one of these middle stages. So we've even covered that ground a little better now, to the point where if we actually give a special therapy that's guided by that biopsy to say, this may respond to a targeted therapy or might respond to immunotherapy, we can do that not only after surgery to make sure all the microscopic disease that could come back and hurt later is gone, but even sometimes before surgery. And what we found with immunotherapy is that we can actually make the cancer disappear from his resection specimen when he serves it in the operating room more often than when we did it with chemotherapy beforehand. So it's quite remarkable. And that's a good sign that we're hitting the tumor when it's microscopic, where it could come back. So that's what makes the outcomes better.
Dr. Klijian, am I getting this right? That there are some lung cancers that you would give this therapy before you even go to surgery and make it so that your surgery is more successful?
Absolutely. Absolutely. The whole point of what I was mentioning earlier about the team approach is to identify the patients that would benefit from that and get them targeted therapy up front before surgery, and that will really give you the best outcomes afterwards.
Well, we're getting quite close to the end of our presentation, but I want to take advantage of the range of expertise that we have here. And remember, our target audience are people who are watching this who may be candidates for lung cancer screening, or they may know somebody who's candidate for lung cancer screening. And I just want to give each of you a chance to say one or two things to people who are watching this, and maybe the take-home point that you had, and maybe we'll just start with Dr. Cheng, and we'll go all the way over to where Dr. Welch is.
Sure. So to all those who's listening, if you're eligible to be screened, or if you even have a question you should be screened, please ask, because it is to your benefit to get screened for lung cancer. And as you know, that, as you heard earlier, that you have a chance of successfully being cured if it is lung cancer, and overall mortality decreases by 20%. It's better than mammography, it's better than colonoscopy. You have a higher impact than that. Please, if you have any concerns that you should be screened, any question, ask and get screened.
I don't think I could say it much better than Dr. Cheng. The only thing I would just add to it is, just on top of it, is let others know, spread the word. So your friends, your family, have them ask their doctor too, because of the advances, the long way we've come, and how much more we can do for this leading cause of cancer death in the United States and the world.
Yeah, we know that we as physicians, we are not doing a good job in educating our patients to do lung cancer screening. Especially in the state of California, we happen to be the last state when we look at the population which should be screened and the number of the patients who are being screened. So I think I really encourage the population, the people, especially the smokers, go to your doctors, ask them if you meet the criteria to be screened. It is something that you should ask. You know, we know that when it comes to diabetes, hypertension, hypercholesterolemia, we know that when it comes to breast cancer, colon cancer, patients go to their doctors and say, my 5 years is up, it's time for my colonoscopy. So please, please, please go and request to be screened. But the most important thing is don't smoke. And if you do, please stop smoking. Thank you.
I couldn't agree more with what everybody already addressed. I mean, when you're talking about cancer, there's a saying, time is money, and time is money. Getting it early is the important aspect of it. You can really impact your survival rate by catching it early. And so I just want to say, don't be afraid. It's not like the treatments have passed, and just if you fall within that criteria of screening, 50 to 80 years of age, greater than 20 pack year smoking history, active smoker, or within quitting 15 years. So not 5 years, not 10 years, 15 years, get the screen.
Yeah, and I'm here to tell you that that the American Lung Association is out there trying to get the word out that you've all been mentioning, early screening, and that's so critical. And the efforts they're putting into this are phenomenal, and particularly here locally in San Diego. So hope to see you at our big fundraising event coming up May 5th, and also be aware this webcast today is part of a community connection webcast series, and you can find at the Lung Association website a library of webcasts that have been put on various topics, including lung cancer, but also asthma, mindfulness, treating lung disease, the dangers of forest fires and smoke. So please look up community connections within the American Lung Association website.
Great. And please say hello to us when you come to the Lung Association events on May 5th. Well, on behalf of the American Lung Association, let me thank our expert panel. This was really an exceptional presentation, and it was a very rare opportunity to get this amount of expertise in one room at the same time. So thank you very much, speakers. Let me close by thanking Grossmont Healthcare District for this beautiful venue, Sharp Hospital System for supporting the entire program, and of course the American Lung Association for sponsoring the whole series of lectures. Thank you.
That's great.
Good job. Thank you. Thank you very much.